When planning your PDPM strategy, the first don't that we want to highlight is to increase your clinical complexity. It's highly advised that you don't chase patients that have higher clinical complexities seeking to get higher reimbursements. By taking on more clinically complex patients, this actually may be disadvantageous to your actual facility. It very well could actually increase your hospital readmissions, decrease your census, increase deficiencies, and subsequently even open your facility up to litigious action. We also advise not to hire ICD-10 coders. There are approximately 68,000 ICD-10 codes available to choose from today. With so many codes, it could be very complex to try to train your staff to become experts in ICD-10 coding by October. We also want to highlight that it's not in best interest to eliminate your MDS coordinators. While the frequency of the MDS has to be reported has decreased under PDPM, the MDS itself becomes more critical. Under the RUG-4 model, there were about 20 MDS items that affected reimbursement. Under PDPM, this increases to 161 items in the MDS. We also want to highlight that it's probably not in your best interest to invest in expensive ICD-10 software. These software tools are not constructed to increase PDPM revenue. They are not designed to pick the appropriate PDPM ICD-10 code. And now that we've gone over some of the don'ts, we'd like to highlight some of the do's when preparing your PDPM strategy. Under PDPM, it will be absolutely critical to have collaboration between all disciplines in treating the patient. It's highly encouraged to analyze your recent admissions to determine the impact of that payment under PDPM starting in October, but also understand your staffing needs. Know the resources that your facility will ultimately need under PDPM. Your staffing levels may very well need to increase if you intend to admit more clinically complex patients. By accepting and admitting more clinically complex patients, it's also advisable to understand what implication that possibly could have on your 5-star quality measures, as well as your hospital ED readmissions and 30-day readmission rates. And lastly, under PDPM, one of the most critical objectives is the importance of the clinical diagnosis, the ICD-10 code, for which is the primary admitting reason that the patient ultimately is in the skilled stay. This ICD-10 code, derived from the attending physician, will populate a clinical category, and further refinement of that diagnosis will promote better documentation both on the physician side as well as the facility side. And ultimately, that physician diagnosis helps drive the reimbursement under PDPM. Those specific ICD-10 diagnoses map over to a clinical category for which the patient will fall under. These are examples of the 10 clinical categories for reimbursement under PDPM. PDPM will require coordination and seamless transition of clinical patient-related information. One way to precipitate better processes is by leveraging powerful technological tools. The use of GPM's Care Team platform can expedite verification of primary and secondary ICD-10 diagnoses from the admitting physician, ensuring a timely and accurate PDPM MDS submission.